Welcome. Thank you for joining us for the NCD Alliance Regional Multi-Stakeholder Dialogue in the African Region, titled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 Era. Can we move on to the next slide, please? Okay, so we have interpretation available today. French language is simultaneous interpretation is available during this session. The feature has already been activated and it is available by clicking the interpretation button at the bottom of your screen, where you can select the language that you would like to hear. Okay. We have more people that just joined us now. For those of you just joining us, thank you for joining us for the NCD Alliance Regional Multi-Stakeholder Dialogue in the African Region, titled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 Era. I am Luismi, and I will be your technical facilitator today. Please use the chat function to message anyone with the title Technical Facilitator in the name for assistance. So it's myself and Pam, Ila, Hermes, my colleagues as well, who also say Technical Facilitator. All right, before we get started, I have a few technical notes to explain. If you would like to contribute a perspective, idea, or thought, please use the chat function. If you would like to ask a question, please use the Q&A button. You can find both of these features at the bottom of your screen window. Please note that this session will be recorded for documentation purposes. We are also streaming live on Facebook to enable a larger audience to take part in this discussion. Okay. I will now pass the floor to Ms. Katie Dane, CEO of the NCD Alliance. Katie, the floor is yours.
Thanks very much and good afternoon, everybody. My name's Katie Dane. I'm the CEO of the NCD Alliance, and I'd first like to welcome you all to this multi-stakeholder dialogue for the Africa region entitled Inspiring Change, Putting People First, Shaping Responsive Health Systems for People Living with NCDs in the COVID-19 Era. We're delighted to have with us today a number of panels of distinguished speakers and with us so many members of the NCD community, both globally and within the African region, including people living with NCDs and other relevant stakeholders. Today's dialogue is hosted by the NCD Alliance with the support of Access Accelerated, a multi-company partnership that seeks to reduce barriers to access to care for NCDs in low middle income countries. And I'd like to say a particular thank you to Access Accelerated for their support and collaboration in making this dialogue happen. For those of you who aren't familiar with us, which I'm sure are not a huge amount of people on the call today, we're a global civil society network bringing together a unique community of 270 members in more than 80 countries, dedicated to supporting a world free from preventable suffering, disability and death caused by NCDs. And regionally in Africa, we're delighted to have 95 members, 22 national NCD alliances and 2 regional alliances who are all very actively leading advocacy, raising awareness and providing essential support to people living with NCDs across the continent. We also work very closely with governments, UN agencies, private sector foundations to translate knowledge and global commitments on NCDs into action. Today's dialogue is very important and timely. NCDs are on track to become the leading cause of ill health, disability and premature death in the African region. NCDs were responsible for 3.1 million deaths in the African region in 2015, according to WHO. And they're set to become the leading cause of mortality in sub-Saharan Africa by 2030. And this is without considering the impact of the COVID-19 pandemic, which is very much the focus of today's virtual regional dialogue. According to current data from WHO Afro, the COVID pandemic has affected up to 47 countries across the region and over 3.3 million cumulative cases, and 83,000 deaths have been reported. And as we are all so familiar with, the NCD community has experienced COVID as a syndemic, with people living with NCDs severely and disproportionately impacted in so many ways. And in the Africa region specifically, hypertension, diabetes, cardiovascular disease, and asthma are the comorbidities most associated with COVID-19 patients. But it's also not just the direct links between the NCDs and COVID that have been so alarming.
I think Katie's connection has dropped. Aminatu, do you want us to move on to?
Yeah, Katie has dropped, but I can chip in. So I'm Aminatu Sarr. I am the Senegal country director. I'm also overseeing our West Africa hub work. And in Senegal, we have an NCD division who is working across several programs. It's really for me an honor to be moderating this important dialogue. As we did it on at the beginning for those who just joined us, so you can have interpretation in French. Donc, pour ceux qui viennent de nous rejoindre, vous pouvez avoir l'interprétation en français en cliquant sur interprétation et en choisissant votre langue. Et vous pouvez mettre en muet la langue originale, comme ça vous serez plus confortable. I'm switching back maybe to English. We really want this dialogue to be as interactive and lively possible. So use the chat, use the Q&A functions on the Zoom platform, share your thoughts and comment on what we are hearing in the chat function. And if you have question, make sure that you put it on the Q&A section so that it is not lost in the chat. We will be monitoring both of that. So COVID showed the fracture points in the health system and showed gaps in providing high quality NCD care. People living with NCD experience a greater risk and exposure to COVID as their solution were not available for them, and in addition experienced disruption in service delivery. This highlights the disparity in system and infrastructure for NCD care. Health systems were least prepared to protect the people with NCDs during COVID. NCDs are one of the most poorly invested in health areas, which compounded the already increased risk people living with NCD had of getting severely ill with the virus. There are so many rapid, effective adaptations that were made to HIV, TB, and malaria services that could have also been applied to NCD. So as we are working with our partners, including the NCD Alliance, to ensure that access to NCD treatment is incorporated in health system resiliency after COVID, and that people living with NCD are not forgotten why we are still in the thick of this global crisis. So this is part of a series of regional multi-stakeholders dialogues hosted by the NCD Alliance between May and June this year. And we are starting with the Africa region. This Africa multi-stakeholders regional dialogue is seeking to discuss region-specific people-centric approach to address NCDs, ensuring universal health care and leaving no one behind in order to build back better and fairer for the COVID-19 pandemic. We will be doing this by hearing our wonderful speakers who will be sharing their perspective and experience through 3 phases. We'll have a keynote from Professor Omilola and 2 panel discussions seasoned with live experience advocates. After each panel, we'll have a 20 minutes of fireside chat, starting with a planned intervention, followed with a Q&A session with all of the audience. So we really encourage you to send your question in the Q&A box, to chat with while we are talking, and you can direct them to our distinguished speakers and any participant to this discussion. And the speakers, I'm sure, will be happy to answer any of your questions. So this being said, I'm really pleased to introduce Dr. Babatunde Amilola as our keynote speakers. Dr. Amilola is currently leading the Division for Public Health, Nutrition, and Social Protection of the African Development Bank. In this position, he's responsible for managing the bank's multi-billion-dollar response to the COVID-19 pandemic in Africa. And when it comes to financing, putting people first is critical. Dr. Amilola, thanks for being with us and for unpacking the concept of putting people first, considering realities of the region and current context. Over to you, Dr. Amilola.
Thank you very much, Madam Moderator, and greetings to all participants. I want to thank you so much for inviting me to be your keynote speaker on this very timely topic, especially in this era of COVID-19. Let me begin by saying that non-communicable diseases that you can also call chronic diseases, because of their long duration, have been affecting many parts of the world, especially the African continent. What we know globally is that non-communicable diseases kill about 41 million people each year. 77% of all NCD deaths are in low and middle income countries. And of course, as we heard from the CEO, the main types of non-communicable diseases are cardiovascular diseases, cancers, chronic respiratory diseases, and diabetes. These four groups of diseases account for over 80% of all premature non-communicable disease deaths around the world. There are so many socioeconomic impacts of non-communicable diseases. One of them, of course, is that poverty is closely linked with non-communicable diseases, and the rapid rise in NCDs is forecasted to impede poverty reduction initiatives in low-income countries, especially in African countries. And healthcare costs for non-communicable diseases can quickly drain household resources, delaying progress towards the SDG agenda, which includes a target of reducing premature death from non-communicable diseases by 1/3 by 2030. So it's a big challenge for us. And we know that we have a target specifically to reduce premature death from non-communicable diseases by 1/3 by 2030. And this is what we work towards at the African Development Bank. Let me also mention that our NCDs disproportionately affect people in low-income countries more than any other part of the world. And in terms of Africa, we've seen the landscape. What we know from the World Health Organization is that deaths from non-communicable diseases are likely to increase globally by 17% over the next 10 years. And the African region will experience a 27% increase. This represents 28 million additional deaths from non-communicable diseases, which are projected to exceed deaths due to communicable, maternal, perinatal, and nutritional diseases combined by 2030. So it's a big deal. The largest relative increase in non-communicable disease deaths globally in this decade is expected to occur in Africa. And as we know, there are many drivers and determinants of non-communicable diseases in Africa. Some of them, of course, that we know are population, rapid urbanization, and unhealthy lifestyles. Now, what do we need to do in terms of preventing, controlling non-communicable diseases, especially in Africa? We need a people-centered approach to do this. What we know about the 2018 Non-Communicable Disease Political Declaration is that that declaration acknowledged the role of people living with non-communicable diseases in the response to non-communicable diseases, reflecting a shift towards a more inclusive and people-centered approach founded on the SDG principle of leaving no one behind. So what would a people-centered approach mean for us? It will require for us meaningful involvement of people living with NCDs to contribute to decision-making processes for health. This includes working towards integration of non-communicable diseases into universal health coverage policy and implementation to combat fragmented health systems. We also must invest in improving NCD surveillance and conduct research to rectify gaps in the current evidence base that we know. And as we know, when you look at the World Health Organization, they have come up with some 6 things that can be done in terms of preventing non-communicable diseases. I will just mention them very quickly. One of them is to reduce tobacco use. The other one is to reduce harmful use of alcohol. The third one is to reduce physical inactivity. The fourth one is to reduce unhealthy diets. The fifth one is to manage cardiovascular diseases and diabetes. And the sixth one is to prevent and manage cancer. Now, because I'm talking to you from the African Development Bank Group, where we believe that finance is really important. And for us to really address non-communicable diseases, we need to finance the response to non-communicable diseases. So I'll give you a few statistics on what is going on. Despite the fact that non-communicable diseases represent the cause of 70% of all global deaths annually, the amount of development assistance for health received globally is less than 2%. It's less than 2%. This, of course, shows general disinterest in funding the NCD response. And that means that widespread chronic illnesses tend to translate to decreased labor outputs, lower returns on human capital investments, and increased healthcare costs. The rise in non-communicable diseases will create a multiple burden of disease for already overstretched health systems, as we have seen in the case of COVID-19 in Africa. So now the current health infrastructure in Africa is not yet ready to cope with its rapidly growing NCD burden. And that's why for us, I believe that 3 areas are important if we really want to ensure that we finance the response to non-communicable diseases in Africa. The first one is that we have to focus more on universal health coverage by ensuring systematic health system strengthening instead of multiple disease-centric responses that we have seen around the world. So universal health coverage will help us reduce inequality, remove barriers to access, and will help us to drive community action. And this is important for us to do, especially if we want to achieve the health-related sustainable development goals by 2030. The next thing that we need to do is that we need to invest in health infrastructure development. One of the things that we have witnessed from our side is that lack of consistent planning for healthcare infrastructure, inadequate funds allocation, and skilled staff compounded by budgetary costs have left public health sectors in Africa ill-prepared to cope with growing NCD burden. And so we have to deal with it. The third thing that we believe in terms of financing the NCD response we need to do is to invest more in digital health technologies. This would help us to push healthcare to empower patient involvement in their own care, and we need to do this. Let me now say that financing the NCD response will require high-level commitments. It will require a lot of political will, but it will also require multi-stakeholder partnership to get this done. And there are many ways we can get this done. But let me just highlight 6 of them very quickly. One is through intelligent taxation. Could you please repeat that?
No, I was saying yes, to wrap up with your 6 takeaways, yeah.
Okay, thank you. So financing mechanisms will include intelligent financing, intelligent taxation, impact investment, innovative financing, catalytic funding, and all of these can be done. Let me say from the African Development Bank side, one of the areas where we believe health sector is important, it's that there are many ways to strengthen health systems, and partnership is one of them, and that's why we're really very happy about this. And this is what we've been doing in terms of COVID-19 response, in which our board approved a $10 billion COVID-19 crisis response facility for the continent. And part of that is going into building private sector and public sector collaboration. Let me conclude with three statements very quickly. The first statement is that non-communicable disease deaths will be the largest in Africa within this decade, prompting an immediate need to adequately prepare the continent's health system. The second statement is that the role and contribution of people living with non-communicable diseases and civil society must be meaningfully involved in decision-making processes for non-communicable diseases at the global, national, and community levels. Finally, investing in non-communicable disease prevention and treatment requires commitment from national governments to increase domestic funding and develop an enabling environment for private sector involvement. And all of this can only be done through meaningful partnerships and through dialogue such as this. Thank you so much.
Thank you very much, Dr. Amilola. I think that you've beautifully framed the reason why we are having this dialogue, the fact that NCD affects the low and middle income countries more than any other region in the world. At the same time, general disinterest to invest in the NCD files. And of course, we are talking about people. And people are not diseases. That's why I would like really to invite Christopher Komla Agbeba to tell us why people and communities must be center stage in building back fairer for the COVID-19 pandemic. Mr. Agbeba is a person living with a disability and is currently a member of Our Vision, Our Voices Global Advisory Committee on NCD. He currently works at the Ghana Federation of Disability Organization as the COVID-19 project officer. So thanks in advance, Mr. Christopher Agbeba, for sharing your lived experience.
Thank you so much for the opportunity to also speak and to once again share my experience. What I'm also going to do is that with the vast knowledge that Dr. Babatunde has just laid as a foundation, I am going to drive home a point. And my point is the word, and I'm going to use the word impact to drive home a point. But first of all, I would want to say my heart goes out and a word of prayer to everyone in the continent of Africa who is going through the wave of COVID, and its impact has been extreme and it's been alarming. We've been following what has been going on in our sister countries and other countries across the continent and also across the world. Our hearts goes out to everybody for going through what we are currently going through. And just like I said, I'm going to drive home this point by using the word impact. The all-round effect of COVID-19 on persons living with NCDs has been extreme and severe. And if anyone tries to downplay that fact, then it means that that person is actually spectating and not paying attention to what is going on. Before COVID, persons living with NCDs were going through diverse levels of challenges: access to healthcare, access to specific services, the stigmatization and discrimination, even from the community and society in which they find themselves, and all manner of issues was the situation that persons living with NCDs went through even before COVID. So what COVID has come to do is that COVID has taken the impact of living with a condition such as an underlying health condition such as an NCD from one worse point to an extremely worse scenario. Using myself as an example, where my medication, the cost of my medications have been increased, but my universal health coverage system doesn't cover my health needs. And I'm speaking generally for the NCD community going through a lot of the challenges within this period. Unfortunately, the government and the implementation or the kinds of interventions that the governments are coming out with do not factor the key needs of persons living with NCDs. Let me even drive this home. A lot of people are happy with the rolling out of the vaccines. But one thing we need to understand is that for some categories of persons living with NCDs, even the vaccines, they just can't take it without going through some level of scrutiny where the health professional needs to actually lay them off their medications for a period and then take the vaccine before they get back to medications that they take on a daily. Because for us, we take medications on a daily. So like I said, I'm not going to really reiterate a lot of the things that Dr. Babatunde has said. I want to drive home this. So if COVID has had impact and a worsening impact on persons living with NCDs, one thing we need to focus on is that if we really want to curb this impact, we need to focus on those that it has impacted the most, which is persons living with NCDs. The meaningful involvement is way important. We can't even lay it down even any much more harder, because we've pounded on it and we are pounding on it today by saying that all of these interventions that the government is rolling out in Ghana, in other parts of Africa, should be people-centered. And by people, I mean persons living with NCDs. It has to capture their needs. It has to capture their lived experience. There's nothing that is above the lived experience. As we speak right now, people are experiencing what I will call a crisis, which is actually giving them a certain lived experience. And the resource of the lived experience is what is going to drive home the impact that whatever intervention we roll out, once it includes persons living with NCDs being a part of the policy itself, the implementation, and the monitoring to ensure that this particular policy is actually driving home the impact that we are looking for, then we are not really going anywhere. Like I said, I don't want to, because of time, I wouldn't want to drive or reiterate most of the things that Dr. Babatunde has said. But let us understand that if we are really looking at making an impact, then we need to invest highly in the needs of persons living with NCDs, because once we do that for them, trust me, we are doing it for everybody. Thank you.
Thank you very much. I think that was a great plea and advocacy for investment on NCDs and people living with NCDs who you think was the most impacted by this COVID-19. I think that this has been really setting the tone of this dialogue. I'm just reminding you that all the attendees, so you can send your questions in the Q&A section. You can chat and give your thoughts on these discussions and that Dr. Babatunde and Mr. Agbega have already shared. It is really a time for you to share as much experience and lived experience that as you had to fuel the conversation. So I think that our both first presenters have really put it at the right tone. We are now going to have our first panel discussion on shaping the future of NCD by putting people first. Just a regional perspective on the importance of community-driven approaches. We will hear from 4 distinguished panelists. First, Professor Jean-Marie Dangou, who is an NCD program coordinator at WHO Africa. Dr. Ifan Tusson-Mare, Department of NCD at the Ministry of Health of Kenya. Ms. Leah Kilenga, founder and director, Africa Sickle Cell Organization, and Professor Kaushik Rameya, president-elect from the Africa NCD networks. These are our distinguished people who will really take us through this panel discussion. And I will be starting with Professor Jean-Marie Dangou. You are currently the coordinator of the NCD management program at WHO Africa and are fully involved in the response to the COVID-19 pandemic. So given the many intersection of NCDs and COVID-19, what are the main health systems impacts exposed and disruption in NCD services observed during the COVID-19 pandemic?
Thank you very much, Madam Moderator. Ladies and gentlemen, all protocol duly observed. It gives me great pleasure to participate in this important panel discussion, sharing WHO's perspective and the major learnings from the intersections of NCDs and COVID-19. WHO conducted 2 rounds national pulse survey on continuity of essential health services during the COVID-19 pandemic to gain rapid snapshot of changes and challenges in service delivery, but also in service utilization, in support, policy, and planning dialogue. The survey also aims to identify critical bottlenecks and priorities, recommend mitigation approaches and solutions, and also guide resource investments as pandemic progresses. Round 1 was conducted between May to September 2020, and 33 African member states participated in that survey, which was a global one. But I will extract the data from the region and share with you. More than 69% of countries in our region reported 26 to 50% disruptions in hypertension management, cardiovascular emergencies, cancer treatment, diabetes management, asthma services, and urgent dental care. During round 2, which was conducted between January to March 2021, 40 African member states participated. More than 50% of countries reported disruptions in cancer screening, urgent dental care, cardiovascular emergencies, and diabetes management. Except hypertension management and cancer management, percentages of disruption of NCD services are higher in the WHO African region than globally. Policies, plans, and mechanisms to maintain essential health services were recommended and implemented after round 1 and round 2. The recommendations include community communication, engagement, recruitment of additional staff, training to identify priorities, redirection of patients to alternate healthcare facilities, self-care interventions where appropriate, task shifting, role delegation, and integration of several services into single visit and novel dispensing approaches for medicines.
Yeah, thank you, Professor Dangou. So how can we ensure social participation and meaningful involvement in building resilient people-centered health system and emergency preparedness plan in view of what you've already said?
On the side of WHO, and particularly in the context of COVID-19, as said by previous speakers, it's important to ensure people-centered care, as well as building resilient health system. And for us, we should engage and work in the following direction. First of all, we should engage and empower people and communities by promoting health literacy and related approaches. We should also strengthen governance and accountability by identifying and strengthening mechanisms to engage communities, CSOs, and in processes of governance, planning, and priority setting, but also service delivery. And we should also engage in dialogue with policymakers and leaders to foster the creation of environment and culture. We should also reorient and coordinate the service within and across sectors by assessing the strength of the community, but also strength of stakeholders, as well as relationships, and embed processes for understanding their needs and preferences. We should integrate people and community needs based on services to universal health coverage packages, as well as emergency preparedness. I think, last but not least, we should also train professionals on community engagement, how to interact with the community. Thank you very much.
Thank you very much, Professor Dangu. And I was hearing promoting health literacy, but at the same time engaging the government's accountability in addressing NCD. This leads me to turn to Dr. Ifante Samare from the Department of NCD at the Ministry of Health in Kenya. Kenya has been working closely with your department, Dr. Mare. And in your opinion, in what ways has the COVID-19 pandemic revealed the need for more concrete and meaningful involvement of civil society and people living with NCD, this to ensure people-centered health and development plans?
Thank you very much for giving me this opportunity to highlight how Ministry of Health Kenya has involved people living with the civil society and people living with NCDs when it comes to COVID-19. I would want to start by alluding to the fact that the pandemic has shown the need for even greater and sustained involvement of civil society in complementing government effort. This came in particularly on the onset of the COVID-19. As a ministry, we were able to conduct a rapid assessment of NCD health services during the pandemic. And we had some interesting findings, such that 23% of all health facilities lacked essential drugs for hypertension and diabetes. That notwithstanding that of all our COVID-19 cases, 43% were associated with comorbidity, and most of these comorbidity were due to hypertension and diabetes to the tune of 70%. So with this in mind, we also realized that close to 38% of health facilities did not have mechanisms to directly communicate with the persons living with NCDs, and therefore this agitated need for ministry to work very closely with civil society and people living with NCDs to make sure that we have continued and sustained health services, NCD services, which included mental health and psychosocial support. And to this end, we were able to form a COVID-19 committee that had representatives from civil society, people living with NCD, private sectors, and other partners. So this way, we were really able to increase the reach and access for health services to people living with NCD during the pandemic. Again, we were also able to realize that there was fear, misinformation about the pandemic. There was also vaccine hesitance, which was occasioned by the pandemic, and this revealed the need for empowerment of people living with NCD, not only from information perspective, but also in planning and making key decisions within health. I would also want to mention that the civil society came in handy to support ministry, particularly during the pandemic. The civil society was even able to do a letter to our cabinet secretary or minister for health, and their intervention resulted positively into developing of quite a number of documents which we were able to use, and we continue to use them during the pandemic. Thank you.
Thank you, Dr. Mare. So, has the pandemic been a light bulb moment for public and political perception of the importance of investing in NCDs and prioritizing the needs of people living with NCDs as part of the national COVID-19 response in Kenya?
Thank you very much. I would want to say a big yes. COVID-19 has revealed the vulnerabilities of the health system to support persons living with NCDs. And due to this, it has been realized that it is very, very important to prioritize NCDs and also invest in NCDs. This was closely observed, particularly during the early days of NCDs, early days of COVID-19. It was realized that NCD clinics and as a service delivery point were converted into COVID-19 centers. This leaving our persons living with NCDs with nowhere to go to. And therefore, but with the time, we realized that there was even a greater need of delivering service to people living with NCDs, and we were able to revise this. I would also want to say,
yes, I may have the last question for you. What is the value of exploring people-centered models for the different stakeholders in the health system in the context of NCDs and health equity more broadly? In your
thank you very much. People-centered models ensure designs of interventions is patient and community-centered, feasible and acceptable. Our constitutions mandate public participation in policy, planning, and budgeting. As a Ministry of Health, we believe in co-creation with our client, i.e. civil society, people living with NCDs, and our frontline health workers, health managers, civil society, among others. It is for this reason that the NCD Intersectoral Coordinating Committee was established in this country, and it is co-chaired by Director General of Health and also the NCD Alliance chairperson in this country. And it is through this that Ministry of Health has been able to work very, very closely with the civil society and other non-state stakeholders, particularly the civil society and people living with NCDs. Moving forward, people-centered models will ensure that the inequities that exist due to digital and health literacy are reduced. Information is very crucial and this should be adapted to suit the patient's background. Additionally, digital platform for both information and service delivery will ensure a health provider can reach persons living with NCDs who are disadvantaged by either geography or finances. Thank you.
Oh, thank you, Dr. Mare. I think that all our governments are aware of the needs in investing in people's health in this pandemic period. And I would like to really hear Leah Kilenga Masomo. Leah, you are the founder and director of the Africa Sickle Cell Organization. As a person living with sickle cell anemia, what does a people-centered health system mean to you? And why is it essential to address NCDs, ensure universal health care and resilience and recovery from COVID-19?
Thank you so much, Aminato, for the beautiful introduction and all the panelists. So the advocacy agenda of meaningful involvement of persons living with NCDs says there is power in the lived experience. So in my 30 years and a lifetime of experience of interacting with the health system as a patient, I think the greatest achievement in healthcare processes has been and continues to be involvement of people. My understanding of people in the word people-centered is the range of stakeholders in and outside health whose participation and collaboration allows everyone to win. especially the most vulnerable populations and people living with NCDs. So as an advocate and as a person living with sickle cell, an NCD that has been under prioritized globally in the NCD response and notably in the region, I have come to appreciate NCDs, the complexity of the disease, how we finance it, and the way we respond from the prescriptive top-down approach to now the more inclusive participatory bottom-up approach. And I feel that for Africa as a region to achieve its fullest potential, we need to be people-centered. And for UHC, I think we need to, in a sense, shift our thinking to transform our systems and structures. People, in my opinion, for people, in this case, means leadership needed to ground ourselves in the ethos of access of quality healthcare equitably and safeguarding lives and livelihoods. And people in terms of affected communities who can contextually inform these frameworks and hold the fabric of people-centeredness, and the people in terms of stakeholders like all of you together in the true Ubuntu fashion of Africa to move the whole society towards this. So for Africa, for this audience specifically, I believe social cohesion of all stakeholders and our ability to come together, especially during a disaster that is COVID-19, NCDs, and everything that we bear as a region, shows the ability of Africa to be resilient, to recover, and allow us to rebuild for people living in NCDs, for communities across Africa to live fully. We need to prioritize people-centeredness in this region.
Thank you, Leah. I think that you are exactly a person who can share with us any inspiring example that reinforce the case for meaningfully involving communities and people living with NCDs and civil societies in the COVID-19 response. Anything that you would like to share with us?
Yes, so I have two examples, two contrasting examples, which are very similar. So this is the case of Kenya's caucus of people living with NCDs that I am a part of. So before COVID, there was no caucus of people living with NCDs. What is unique about Kenya, the NCD Alliance of Kenya prioritize meaningful involvement of people living with NCDs and invest substantially in this agenda. And as a matter of fact, without this intentional development, we will not have achieved all that we have. So the caucus was developed amid the pandemic, essentially by people's shared problems of our lack of access or essential medicines. And the Alliance came in to essentially allow us to have this platform that has successfully allowed us to formulate press releases, campaigns that successfully advocated to open clinics that were initially closed, avail medicines, provide social support for people living with NCDs. And now I know what they're doing is actually prioritizing vaccination for people living with NCDs and the long-term nature of developing the NCD strategies for Kenya. The second one that is most notable is the WHO informal consultation of people living in NCDs, where initially we would have known the WHO to just be WHO and bring people there. They came down to us. And for me, that was a huge step that has cascaded from the galvanization of years of efforts of the NCD response globally, regionally, to this realization of the importance of meaningful involvement of people living with NCDs. And I am happy that Africa is leading this dialogue to achieve and to realize people-centeredness in the region. So for me, those are the two shining examples I can give.
Excellent example, very inspirational. I am seeing some of the participants cheering on and congratulating you on really sharing your lived experience. I see also that some of the participants are sending the questions in the chat. I would just invite them to transfer them to the Q&A session so that we don't forget to answer to them. Donc, tous nos participants qui sont en train de mettre des questions en français dans le chat, vous pourriez peut-être les transférer dans le Q&A Comme ça, nous nous assurons de ne pas les oublier. Thank you very much, Lee, for sharing. I think that there are a few things that came in the previous conversation, like the need to have evidence-based data for programming, and also the need to put the people in the center. And the example you shared, Leah, brought me to maybe call on Professor Kaushik Ramaiah. Professor, you are not unknown to us as you are the technical advisor to the Coalition for Access to Medicines, NCD Medicine and Products, in which PAS is a secretariat. But you are also the president-elect of the Africa NCD Network, and your role with the Tanzanian Ministry of Health on the National NCD program encompasses prevention and promotion, curative services in primary care, training, policy and legislations, monitoring and evaluation, and operational research. A lot that you are doing. So citing examples, case studies from before and during the pandemic, could you shed some light on the role of the health workforce in effective community engagement for the prevention and control of NCDs?
Yeah, thank you very much. First of all, I would like to thank NCD Alliance for giving me this opportunity, and it's a privilege to be on this panel. I think the question you ask is very relevant, is that how can people with NCDs or people with the disease play a catalytic role in ensuring that the quality of care being provided to them is of an optimum standard and a good quality. I think talking on out we're ahead of the Tanzania Diabetes Association or Tanzania NCD Alliance, looking at an example within the Tanzanian setup, is that we as a Tanzania Diabetes Association and Tanzania NCD Alliance have always, first of all, worked with the Ministry of Health to ensure that whatever programs we put in place, they are basically sustainable over a period of time, because you might start a program which will fizzle out as soon as the funding goes away. So what you need is a sustainable program. Second thing is that whenever you start any program or you start any initiative, it has to be devised by the people with the disease, because they are the best people to know what will help them and what will not help them. And what we looked at was that initially there was a sort of a dearth of what providing of services you can provide at the primary care and secondary care. And within the context of NCDs, when you look at NCDs, even when you do a community screening, when you do an awareness, if you are identifying people who are not been diagnosed previously, or you have diagnosed people who have been sort of having a disease, an NCD, which has not been adequately controlled, you need to refer them to the health system. So unless you build your health system infrastructure well, it is very difficult and very frustrating for somebody to be diagnosed and not be able to access the healthcare system. So our target has been initially building the infrastructure, making sure that all these people with their NCDs are able to access care, and access care at a primary level, secondary level, and tertiary care. And what we have done is built series of clinics whereby initially we started as a diabetes clinics, but they have slowly converted into NCD clinics. And it has been sort of a partnership between the people with the NCDs and the healthcare providers and the Ministry of Health. At the same time, I would say, as a group of non-communicable disease alliance, we have been actually able to work with the ministry in trying to frame the policies, the regulations, reviewing the regulations to ensure that there is a conducive environment. There are always challenges in whatever you do, but basically, if you are perseverance, then it is usually successful to do that. And a classical example is that when we had this COVID first wave, which came in 2019, we as the Tanzania Diabetes Association, Tanzania NCD Alliance, managed to get some funding, whereby we looked at 4 components of the COVID crisis. One was, how do we improve the awareness of the community, especially with people with NCDs, and how do you, because they were the people who are getting affected with COVID morbidities and mortalities. And we wanted to ensure that they basically take care, they do preventions, and they make sure that they do not basically get the COVID And if they have somebody within their household, how do they take care of that person? So we actually looked at community approach, we looked at the school health approach, and we looked at the market approach of how do we restrict those components from the community. Second thing, we built the infrastructure within the public health sector, trying to see that where if people with an acute emergencies do go to these public facilities or private facilities, how do you ensure that we are ready to manage acute care for these patients? And the third thing was looking at the supply chain. At some point, we also looked at, because a lot of these people with NCDs got frightened of coming to the health centers because they were worried that they will get infected. So there was a component of an outreach program with the mobile services trying to ensure that we go to the places where they live so that we can provide them the control, we can provide them the services. And that was a pilot which we did in Dar es Salaam, and that pilot has been quite effective. At the same time, we also done training of the healthcare providers into the infection prevention control and acute care management right up to the primary care. And the concept is that establish an acute care team. An acute care team is not only a healthcare provider, but it is also a paramedical staff, it is also a health facility volunteer, and it is also a person with the disease. And they form an acute care teams, and they know exactly how best to do the triaging of a person who comes with an acute episode. So I think there has been a very active involvement of the people with the disease, with the healthcare providers, with the policy makers, and within the health system.
Oh, that's really very important and interesting insight that you have there. So are there some lessons learned moving forward that you would like to share? And how can the meaningful involvement of people living with NCD be enhanced and supported in health services design?
I think I would say, based on our experience, I look at three components. I think one is they know best what service are they accessing and what is good. So your quality of care has to be of a higher standard if you want people to access your care. And that relates to what we call as a clinical audit, or trying to see, and within that clinical audit, looking at the perspective of a person with the disease, looking at the perspective of a healthcare provider, looking at the perspective of the community at large. That is one. Two, within the planning, sometimes you get innovative ideas from people on the ground, or the people with the disease. So you as a healthcare provider, you might be having the highest degree of education, but there are certain simple things which could make a grand change will come from the people with the disease. And I think we should be ready to listen, and we should pick up what is actually going to improve and make our health systems much more efficient. Third, the biggest challenge is the supply chain. And talking about the supply chain is that the last mile is that right from the, what we call as from the health facility or from the medical stores department to the health facility and going to the person who is living at his home, how do you make sure that they get their essential supplies? And that supply chain, I think, is very crucial, because at the end of the day, this person needs medications, he needs commodities to make sure that he's well controlled. And if you are not able to provide, you might give him the best of quality of care, but if you cannot get the medicine at the end of the day, that is a major challenge. So I think those three components need to be coming from the people with the disease so that you can fine tune them and you can make sure that they become efficient. Thank you
really, Professor Kaushik, and thank you to all our other panelists. Now, Professor Kaushik, we're talking about listening, and I would like to introduce our first fireside chat by inviting Ferdinand Sonyoy from Cameroon Civil Society NCD Alliance. Ferdinand is the president and CEO of the Reconciliation and Development Association, which is a non-profit that promotes community development by driving sustainable solutions to health, education, and peace challenges. So he will showcase community-driven innovation through civil society. Many thanks, Ferdinand, in advance for sharing.
Thank you very much. And I want to first of all start by thanking the NCD Alliance for this opportunity to be on this program. and also to acknowledge the great information that we have had from our previous speakers. I would like to start by saying that in March 2020, Cameroon still had about 10 cases when the government placed of COVID-19, when the government placed some very strict indefinite measures to counter COVID-19. And on our observation, there was really no indication of the potential challenges that those who were vulnerable, like people living with NCDs with pre-existing conditions would face, and the measures that would be accompanying these government measures to support them through those measures. And so by August, the Cameroon NCD Alliance, of course, with support from the Solidarity Fund of the NCD Alliance, we embarked on a process to develop an advocacy and communication strategy that will enable us try to ensure that people living with NCDs were prioritized in the response for COVID-19 in Cameroon, and that this was done within the context of universal health coverage. So we conducted some reviews. We looked at reports that had been put out, as well as the plans from the response committee, and also from different stakeholders that were reporting on their activities in response to COVID. And we were looking specifically at how these responses were considering people living with NCDs. So we also decided to speak with a good number of government leaders who were in charge. And so we gathered information. We also spoke with people living with NCDs so as to really get their perspective and what was happening during that COVID-19 period. And so as a result of our research activities, we were able to come together as an alliance. We're about 11 members, and we elaborated we looked at our report, our findings, and got together some key messages that we needed to take to different stakeholders, including the government, as well as the public and other people working on NCDs in Cameroon. And so we identified some very interesting gaps that we had to try to start putting to field. For example, it was clear that during the response plans, there was really no intentional focus on people living with NCDs as far as the response to COVID-19 was concerned. There was really also lack of data about the whereabouts. Like, even if you wanted to support people living with NCDs, you wouldn't know where they are, and that was really lacking. There was no information really about their needs, the specific needs of people living with NCDs during the period. So it was really interesting to find this level of non-engagement with this particular direction of work. So when we validated our findings, we were able to prepare them in different versions, English and French versions. We translated them so it could have a bigger outreach. And we paid a visit to the Ministry of Health, an advocacy visit. And after we had a discussion with the ministry regarding our findings, we also organized a press conference where we proffered a couple of solutions to the particular challenges that we found. And one interesting outcome is that we were invited onto the table as a civil society, as a group, to be part of the National Response Committee. And so since then, we've been trying to make sure that there is inclusion of issues of people living with NCDs into the response. And that also includes what the placement, the priority of people living with NCDs with respect to vaccines, because we're advocating to make sure that wherever the vaccines are present, people living with NCDs are prioritized. We have seen that happening already. And so we have used our opportunity to be on that table to keep making sure that press releases that come out and conferences, that they include information that supports people living with NCDs. So there's much to do, and we keep on looking forward to more. Thank you.
Yeah. Definitely, many thanks, Ferdinand. There is much to do, and I am sure that the gaps that you've identified in Cameroon are very familiar to what is going on in our other African countries. Thank you for sharing. Wow. I see that the chat is very active. The Q&A also. So many thanks for sharing. I'm just going to look through some of the questions. Some of them has been answered live already. Just reminding that to our panelists that they can answer live in the Q&A session some of the questions. But we still have some pending questions. One coming from Kingsley Akinroye, I hope that I've said it correctly, from the NCD Alliance in Nigeria. So it's a question for Dr. Babatunde. So Kingsley is asking whether the African Development Bank is reaching out to national NCD Alliance in Africa. Dr. Babatunde? I am maybe moving to another question while.
Yes, thank you so much. Thank you for that question. Can you hear me?
Yes.
Yeah, very much. Okay, yeah, the way we work as African Development Bank, we have our regional member states. The regional member states are all African countries that we provide support to, you know, but in addition to that, we engage with the private sector. We do what we call non-sovereign operations, which are basically operations for the private sector. But in addition to financing, we do a lot in terms of multi-stakeholder dialogue and collaboration and partnerships. Part of what we do is within the Harmonization for Health in Africa, which is led by WHO Africa Regional Office. And in that, of course, we have some different partners, you know, UN agencies and the rest there. So specifically when it comes to national NCD offices, we engage in terms of dialogue, in terms of guidance, in terms of community level action, especially wherever we provide resources to support. Look at, for instance, the COVID-19 response that we're doing across Africa. When we provide this kind of support, we engage all different critical stakeholders in every country, at the country level. And these usually tend to include our NCD national offices as well, to be part of that. But going forward, we want to be more deliberate in our action. And that's one of the reasons why I am participating in this particular dialogue, you know, so as to engage more with our NCD national offices going forward, especially in terms of advocacy, in terms of communication, but also in terms of community action at, you know, on the ground, you know, at the community level. Thank you.
And there is another question about how can finance institutions as the African Development Bank play an active role in working with countries towards funding behavioral intervention to prevent the NCDs, ensuring that we don't add to more morbidity numbers at the first place? It is a question from Ashwin Kadambi.
Yeah, thank you again for that question. As I said earlier on, you know, the way we work as a bank is a lending institution, it's a financial institution, you know, multilateral development bank. We work mostly with our regional member countries in terms of financing. But when we do so, when there are, for instance, emergencies such as the current pandemic, or when we had the Ebola crisis, we work with countries, we provide financing. And then from there, we engage even non-governmental organizations so that they can be part of the executing arms of our operations. So when it comes to the details in terms of behavioral patterns, you know, NCDs and all of that, we did a lot in the past, you know, when it comes to, we have even created some centers in Uganda, in Rwanda, to deal with some of the medical issues and, you know, that are affecting African countries. But nevertheless, we are currently putting together, we are finalizing our first strategy for quality health infrastructure for Africa. And in that particular strategy, we are making sure that we deal with issues around partnerships, and we want to be more deliberate in our action so that as a bank, we don't just respond based on ad hoc issues, but we respond very adequately. We ramp up the health infrastructure need of the continent, and that, of course, will help us to deal with also behavioral issues and many other health-related issues that we need to deal with on the continent. So my presence here today should already show you that we want to engage more with different actors and stakeholders, including the NCD community on the African continent. Thank you.
Yeah, thank you. And I would like to invite all the other panelists to answer some of the questions that are in the Q&A. But I would like to ask to Dr. Mare from the Ministry of Health in Kenya. There is a question from Ian Botela, who is asking, could you delve more into the regional relationship starting with Kenya in comparison to Rwanda, Tanzania, and Uganda between stakeholders when approaching policy development on issues such as SBS tax, marketing of unhealthy food, food labeling, etc. Dr. Mare?
Thank you very much for that question. I would want, first of all, to comment on the issue of tax, particularly for sweetened beverages. I know we have been having a lot of communique, particularly between the East African community countries, particularly when it comes into at the governmental level, under the auspices of the Ministry of East African Community. We have been discussing this issue of joint tax policy, and particular ministries of health have been involved in these meetings, and we normally have this meeting on annual basis. And therefore, in this area, I want to believe or to allude to the fact that there is a lot going on. That notwithstanding, we have also got NCD East African Chapter, which has also been at the forefront of discussing issues of sweetened beverages. And to this end, we have the NCD East African has been coming up with communique for the East African region as far as that one is concerned. And as a government, particularly Ministry of Health in Kenya, we have been able to give feedback and share with the relevant authorities. And we want to believe we are going to achieve something as far as uniform taxation for sweetened beverages is concerned in East African community. As for the issues of front of package labeling on unhealthy food, I want to allude to the fact that a lot is going, particularly within the Ministry of Health Kenya. We are in discussion with other sectors. More so, I know Minister for Health Kenya has already wrote to Minister for Industrialization to this effect. And out of that communication, a committee has been set, which comprises of various ministries, including finance, health, agriculture, and also civil society. And we are now in the process of working on frontal package labeling. And very soon we should be able to advise our consumers on as far as the health food is concerning. But of course, we are facing some challenges when it comes to law and enforcement of this. But all is not lost. We have achieved quite a lot. And very, very soon the committee should be giving feedback back to the mother ministries. So far, that is what we are achieving as far as health food is concerned. Yes, thank you.
Thank you, Dr. Mare. In the interest of time, we are going to conclude on this fireside chat that was really very interesting. And thank you to everybody for contributing and having participated. There are still 2 questions that are pending, but be assured that they will be answered before we conclude. I just would like us to move to our second panel discussion, where we will explore solutions to mobilize communities in our Africa region for a people-centered response to NCDs in the COVID-19 response. context. So we are going to invite Professor Gérald Yonga, the president of the African NCD network, Dr. Ladi Hamid, managing director of Roche Nigeria, and Ms. Chantel Boyson, mental health advocate from South Africa. I've seen in the chat and the question some questions related to mental health. But I would like to start with Professor Yonga. Professor, you've been involved in NCD advocacy internationally for more than 18 years. You are also the founder chair of the NCD Alliance Kenya, East Africa NCD Alliance, and the Africa NCD Alliance Network, and a board member of the NCD, Global NCD Alliance. And of course, you were also a friend of BAS. Can you just tell us more about how communities have been affected by the pandemic and how NCD alliances have adapted their operations to support communities affected in collaboration with the government, private sector, and civil society? Professor?
Thank you very much. I first would like to thank as a board member of NCD Alliance, to thank my colleagues at the Secretariat by putting this nice piece together, and also our partners, Access Accelerated, for supporting this. As has been mentioned by almost all the speakers in the previous panel, COVID-19 actually really exposed the soft belly of the African health systems in the beginning and even up to now. They were up to around May, June last year, when things peaked. About over 50% of services for hypertension were either partially or completely disrupted. Those for diabetes, up to 42%, were either completely or partially disrupted. Dialysis was also around over 40%, and rehabilitation was, almost 70% disrupted. A lot of staff and facilities were actually reassigned to COVID-19 without any regard to the continuity of care for people living with NCDs, and there was no discussion about it, and everything was done under emergency system. Breast cancer screening was stopped, cervical cancer screening programs were stopped, and literally the whole health system was diverted to the pandemic out of panic and with no previously thought of alternatives in healthcare service in case there is a pandemic. So it really exposed the soft underbelly and the major weaknesses of our healthcare system. And as you notice, all these decisions were made without any community involvement and community participation, where they could have actually helped both the private sector, the business sector, the health sector, the people living with these diseases, to mention just a few, and even the civil societies were not involved in any way at the beginning. It's only after a lot of advocacy, when things were getting out of hand, that eventually governments started to create mechanisms by which chronic illnesses could move forward. And the potentials that were looked at here by most NCD alliances at that time was the possibilities of exercising at home, and there were examples which were being given, the possibilities of telemedicine consultations, and even home deliveries of drugs using local mechanisms like the local motorbikes. In Kenya, they are called boda means of doing things. So a resilient primary healthcare system that is able to withstand an epidemic and continue to offer services for NCDs is quite important. In fact, the most affected communities were people living with NCDs. They were more likely to contract COVID-19, and when they contracted COVID-19, they had the highest morbidity and mortality. A lot of data also was confusing because a lot of NCD mortalities were labeled as COVID mortalities, while actually a lot of them were exacerbations of NCDs with subsequent NCD deaths. So when we talk about communities, what are these communities? So at global level, our organization, Global NCD Alliance, partners with WHO and offered quite a bit of guidance. In fact, a committee was set up, the COVID-19 NCD working group, which worked together with the regional and country NCD alliances to share best practices and solutions to try to address both the COVID-19 pandemic and the ongoing scourge of NCDs. So at ENCDA level, for example, there was a lot of activities. There was even a media training on reporting on NCDs. At country level, through the Intersectoral Coordination Committee, which has been mentioned by Dr. Murray, a lot of collaborative talks took place, leading into a government communique on mechanisms of restarting NCD services amid the continuing NCD pandemic. A lot of professional societies also offered a lot of webinars. Private hospitals in the private sector actually participated quite a bit in offering solutions for possibilities of offering both services of NCDs and COVID-19. A lot of webinars sharing best practices and experiences of managing both conditions took place. Celebrations of world events like World Heart Day, World Diabetes Day, stroke, cancer, sickle cell continued, and these were opportunities for screening for NCDs amid the pandemic. Screening of NCDs in public places also, which involves temperature, could possibly incorporate blood pressure and blood sugar screening, as these are really the people who are most vulnerable. And these are opportunities, again, which were looked at. So, you know, the involvement of different levels of society in decision-making and strengthening a healthcare system that is resilient and is able to absorb a pandemic and continuation of the services for chronic illnesses is not a preserve of government, but really it's a collaboration between all societies that are concerned with human development at home and globally.
Definitely, yes, the importance of multi-sectoral approach. I think that it will speak maybe to Dr. Ladi Hamid. Dr. Hamid, before becoming the general manager for Roche in Nigeria, you worked with colleagues in several countries on policy development and improving patient journeys in different diseases areas. So how do we ensure that the COVID-19 pandemic is a turning point for action in terms of how we revisit the concept of people-centeredness and meaningful involvement of people living with NCDs in the NCD and universal healthcare responses?
Thank you very much, Aminatu, and thank you to NCD Alliance for the invite and recognition to all the other panelists that have spoken. I think a lot of information has been passed about the impact that COVID-19 had on the healthcare system and our weakened healthcare system at that. And I think one of the key things that we saw in terms of collaboration and partnership between the public and private sector was the coming on board of the strength and creativity of the private sector to help to solve a lot of the challenges that patients were having or governments were having in examples like supply chain or getting care to patients' homes or even making diagnostics available. And I think one of the key things that we need to do that we have learned from COVID and to maintain post-COVID is to strengthen the public-private collaboration and enhance policies that will make sure that the private sector involvement is key, because the private sector has surmounted a lot of challenges for whatever reasons, global support, local support, to ensure that their services and products can move from point A to point B and patients can move from point A to point B. One key example we had in Nigeria was the request by the government of colleagues in the private sector joining the diagnostic challenges for COVID-19 to help scale it up through the use of our mechanisms in the private laboratories, so that we couldn't depend only on government resources, but we could bring the power and strength of private laboratories to make COVID testing more readily available and more present. And that really made a change in the COVID testing numbers that we had in Nigeria. And that is something we really need to do, double down on the use of public-private partnerships. I think one other thing that Prof has already mentioned is the use of digital technology. I think one key thing we're already doing in Roche is working with Project ECHO, which is to use GP tele mentoring to ensure, and not only for GPs, I think even for nurses, for lab technicians, or whatever services are needed to ensure that, yes, we can enhance the knowledge, the strength and capabilities of these healthcare professionals across the countries in areas where you have large geographical spans. You can use digital technology to ensure that people are able to keep up to date and also bring the patient's voice to the table by using patient-centric apps. Patients can fill in their data, tell you the challenges they are having, look at the challenges they are having in the patient journey. If we don't understand the patient journey and the challenges that patients are having, moving from awareness to accessing medication, we will never be able to put policies in place that will make a difference in the lives of the patients. I think lastly, one thing that happened very well during the COVID period, and we're still in that era, was data collection and the use of intelligent data to make decisions. That doesn't have to end with COVID. We are not very good in collecting data. And I think one of the earlier speakers said we didn't know where the NCD patients were. We didn't know what to do with them. We didn't know what problems they were having. But with COVID, we saw a lot of good data collection and we saw decisions being made with the data. The question is, why can we not continue this data collection and do in-depth analysis and make decisions based on data that we have to then drive policy that will impact the lives of people? I think one last point that needs to be made, and I think it was Leah who talked about a shift in the way government thinks, and that is how do we create and pay for services? We use a lot of our very minimal resources to buy equipment and build hospitals, and there's nobody really to access the services because patients don't have coverage. Patients in many of our countries have to depend on out-of-pocket payments from their life savings to access care, especially NCD patients. And that really is not good enough. If we challenge our government and we push back on them to cover for services and not to buy equipment, the owners of the services will bring it to the table, and there will be a strong negotiating power for us as Africans or in whatever country to say that, look, we have coverage for 5,000 or 10,000 or 20 million people. What are the best prices we can get? And those services would be made by the owners to work efficiently because they know that if they don't make those services available, they don't get payment. Rather than government trying to be the one who manages that end to end, it's truly unsustainable. And that would be one of the ways we can make a significant impact and a change in the way NCD management services are being conducted today.
Oh, so there is a lot that we need to do. So Dr. Hamid, in just 30, if I say second, what additional actions need to be undertaken to make sure shared values is measured with a people-centric lens?
I think the key thing is data collection and collecting data that truly impacts the lives of people. So when we listen to the patient's voice and we hear what really makes a difference to them, whether it is disease-free survival, it's better outcomes for them, quality of life, we need to look at, are the services we are providing today, is there a difference in the lives of the patients? Do they appreciate it? And then we make policies and changes reflective of that, not based on costs that we are concerned about or a government is concerned about alone. If we pay for proper outcomes, then patients who are at the center will get better outcomes and not just to get a minimal service, which at times is what happens in a lot of our countries. They get the barest minimum of service and then we say, yes, we have done something. Whereas the patient who truly suffers the pain has not really appreciated. And are they getting the same quality of service as in any other country in the world? I think the answer is a resounding no. We really need to change our model of paying for service and then pay for outcomes rather than buying equipment and building hospitals.
That would be a big shift that we're hoping that this is really heard. Thank you very much, Dr. Hamid. I would like now to invite Chantel Boysen. So Chantel, as a South African global mental health advocate and social impact entrepreneur, focusing on creating evidence and solutions to support the mental health and well-being on young people. So reflecting on the past and present, what are your recommendations for responses to the pandemic that could also help save lives from NCDs and prioritize the needs of vulnerable populations?
Thank you, Aminatou. I think I just wanted to first of all say thank you to my other panelists. It's really lovely to be on the same panelists, and they're all very distinguished, and I'm grateful to be here. I'm connecting with you from Durban in South Africa, and my advocacy journey in mental health stemmed from my own experiences of being diagnosed with bipolar mood disorder about 5 years ago, as well as the crippling mental illness that was experienced by my family members. And this all while realizing the effects of mental illness and how it had on my life. It really pushed me to explore the tools of well-being, a curiosity to access mental health care and services, and to drive and initiate small and big initiatives and change in my community, in my country, and globally. So many issues plague people's mental well-being, and these issues are not limited by only biology, but other major influences include social, environmental, economical, and political. Now, it's really not a myth that mental health care has been the orphan of healthcare worldwide for many, many years. And even though there's been significant increase in the efforts in the last 20 years, there still remains a severe lack of adequate mental health care policies, lack of investment and funding in mental health care and services. And there certainly is not even remotely enough preventative and early intervention care and services for people living or experiencing mental illness. And not to mention the lack of support for carers. This already strained economic and social relationship with healthcare systems were magnified during COVID-19. And the funding for vaccines replaced the funding for other essential cares, which in itself is an incredibly short-sighted and a plain absurdity, to be very frank. And it's absurd because if you understand the political context of our country and how misspending, fraud, and corruption plague and diminishes the limited funding that we already have in healthcare. It was evident in our last budget speech by our Minister of Finance that announced a massive reduction in planned spending on public health by billions of rands that equates to roughly 6.6% reduction on healthcare over the next 3 years. Now consider that number and then consider the minimal 5% of that total health budget that is allocated to healthcare, mental health care. And then from that, you also imagine that the majority is spent on inpatient care facilities and a hair fraction is spent on the prevention and early intervention. It certainly is not a rosy picture. COVID-19 had also other massively disruptive effects on our communities. And during certain stages of the pandemic in South Africa, procedures that were deemed elective was not allowed to be prioritized to accommodate for inpatient and COVID care. So this meant that people who experienced or developed health issues like cancerous symptoms, deteriorating heart functioning, or untreated diabetes could not seek medical help or be treated immediately, which naturally had an enormous impact on their life expectancy. So from anecdotal comments that I received from many doctors in KwaZulu-Natal, they had massive increase in patients seeking treatment after the elective embargo, and they often saw patients too late in their diagnosis to treat them adequately or treated them with less hopeful outcomes. And if you times these cases by millions of patients, you can only imagine what the impact is of that situation. In South Africa, and I'm very passionate about this in particular, but in South Africa, nearly 80% of Black people visit traditional healers at least once a year. And we are failing to integrate these community first responders in our healthcare system. In a pandemic, with less access to medical facilities, these visits to healers increases naturally. And this for me is a major missed opportunity for collaborative health interventions.
Yeah, definitely true, Chandra.
I can sit here today and tell you that I am very hopeful about our political environment in which our healthcare operates in our country at the moment. But I must be honest, I'm really struggling with this. I work with and for non-profit organizations who work their hands to the bones every day trying to help our community survive today, to live until tomorrow, and be treated with the issues of yesterday. And it is an enormous task that we need so many actors to work in unison. And currently, our most important actor, our government, is failing every single one of its citizens. So I don't have all the answers here today, but what I can say is that every single one of us is at risk of a deteriorating mental health. In a pandemic, this risk is increased exponentially. And mental health care in many, if not all countries, follows a largely vertical, fragmented, and disease-focused model. And in order for us to actively and realistically attain the 2030 Sustainable Development Goal of good health and well-being, we cannot continue focusing on a disease-focused model for mental health or any other NCDs for that matter. It's just not sustainable. Thank you.
Yes, thank you, Chantal. I think that that is a good conclusion of this second panel, and the need to really think of mental health. We always forget to focus on that as part of the non-communicable diseases. So thank you for bringing up and advocating for that. So I really would like to thank Dr. Hamid, Professor Yonga, and Chantal for this great country regional perspective. I am so sure they will raise many questions and comments. Questions and comments will be addressed during our second fireside chat. So you can ask your question, put your question on the Q&A. We will ask the panelists to answer to the question as much as possible. But before just going back to the questions in the Q&A, I would like to invite Carl Malin to set the tone. Carl, you were the Chief Operating Officer of the EcoBank Foundation, and most importantly, responsible for EcoBank's social impact engagement with the communities in which the bank operates in Africa. Your work at the intersection of public, private, and civil society sectors. So could you just tell us how can governments, multilaterals relevant to private sectors and the NCD community implement a people-centered and integrated approach to improve equity in the context of NCDs?
Thank you very much, Aminatu, and for the invitation also from the NCD Alliance. We're always grateful to collaborate with the NCD Alliance. We went to them about 3 years ago to seek knowledge and best practice, and they responded very positively. And they've helped us actually to provide a structure and a framework to the work that we've been doing at EcoBank and EcoBank Foundation. And they've helped us to think about the work around NCDs in 3 ways. The first one is around knowledge, the second one is around capabilities, and the third one is around financial resources. From our purposes, we decided to focus on this for 3 years. Year 1 was cancer, years 2 was diabetes, and this year is focused on mental health. And earlier, one of my colleagues was talking about 28 million more deaths potentially because of NCDs on the continent. EcoBank has about 26 million clients. So that technically, for a financial institution, that could mean almost wiping the entire assets of this bank because of NCDs. So it's an important thing for EcoBank to focus on long-term issues on the continent that are actually delaying the work that needs to be done for economic transformation. So for us, when we think about equity, it starts with knowledge. So knowledge for us means that we understand what NCDs are, what the issues that the continent face, and we start by sensitizing our 14,000 staff and reaching out to our 26 million customers. Because we believe that when knowledge is actually acquired, it's a good starting point to actually speak about issues that are a little bit, that are softer issues around equity, and what does it mean for somebody to have access to treatment, for example. The second one is around capabilities, and how do we use the 14,000 staff that we have, for example, through the EcoBank Academy, to support the NCD Alliance in financial management. That is important for us because it allows a two-way conversation between bankers and civil society organization, which is facilitated by the foundation, but really the work was done by my colleagues in the EcoBank Academy. So when you use then knowledge and capabilities, it becomes easier to stand on equity because financial resources have to come. People understand what the issues are, they have the capabilities, and we can now really think about how do we make sure that this is done. EcoBank contributed to NCD Solidarity Fund because we trust that civil society organizations are in a better position to be able to address these issues. As a financial institution, we don't have the tools and the M&E framework which is required to support areas such as NCDs. But we do believe that by having a strong collaboration with alliances like NCD Alliance, which works with in different countries for other alliances, we have an opportunity to make a greater contribution to the fight against NCDs on the continent and potentially beyond. So equity is central to how we engage, but we engage it, of course, from the three elements that I mentioned: knowledge, capabilities, and then resources. And this should be, in my view, the way in which other organizations, private sector, and governments engage with civil society on this issue, but also engage with their own health professional. What knowledge do we have about the country? One of my colleagues mentioned the issue about the lack of data. And how much data do we ensure that we have? Another person spoke about the fact that even with COVID-19, we're still thinking in terms of vertical program. We have to vaccinate people. Yet we heard from one of the panelists that for some people living with NCDs, there are some tweaks that need to be made to their medication so that they can actually be vaccinated. But we don't hear much of this in the narrative. And I think thinking about somebody's health and ensuring that anyone, when they access to a health facility, is diagnosed for the issues that they face, and not only for the ones that are funded, it is fundamental to resolve the issue around equity that we're speaking about today. So I'm going to pause here and see if you have any follow-up question, or I'm happy to take some of the questions.
Excellent. Thank you very much, Carl Mala. I think that is a good introduction for the Q&A. I am sure that all this conversation have brought lots of interest and attention around. I'm seeing some of the questions, and thank you for the panelists and the facilitators who are answering to the question. I see that some of the people have their Twitter account. I think that you can just tweet. You want to tweet about this event, hashtag Act on NCDs, to contribute, to continue the conversation with the social medias. But I'm looking at the chat. We still have 4 questions that are 3 questions that are pending in the chat. COVID-19, like Ebenezer is asking, COVID-19 has really exposed the weak health system in our various countries. Governments must scale up action on prevention, control, and management. So management of NCD begins with strong primary health care with an essential package of services for prevention, screening, diagnosis, and treatment, like patient-centered and with clear referral mechanism. And in dealing with NCDs, health ministries across Africa and the world at large must not ignore evidence-based guidelines in the treatment and management of NCDs. These are critical approaches to ensuring standardized and quality care, as well as increasing access and rational use of essential drugs to treat NCDs. So this is Ebenezer's statement, and he's asking, what are the thoughts of the panelists on his comments? Anyone who would like to say something? Be it Carl, Chantel, Dr. Amit, or Professor Yonga?
Professor Yonga is raising their hand. So.
Yes, Professor Yonga. Go ahead.
Yes, I think the most important thing to look at here is really a strong health system that not only looks at the existing problems, but the changes and fluctuations of the health challenges across time. And this calls in the issue of capacity. We must build capacities within the health system, both the healthcare provider capacity, but also the physical capacities that are able to withstand the ups and downs of the health challenges. And then the issue of adaptability of those capacities so that they are deployed elsewhere when not required, but can easily be brought back when in case there's an emergency. More or less the way the armies operate in times of no war. They're used for national building, but in terms of war, they are easily deployed in great numbers to deal with the problem. Then the issue of funding also becomes very, very important. Most healthcare systems in Africa are really underfunded. Most of them way below their budget declaration, more than 15 years down the line. That really makes it a very difficult situation to respond to an epidemic, be it Ebola or COVID-19. So we tend to abandon the existing diseases and systems and jump onto the immediate emergency problem. Then the issue of multi-stakeholder involvement also becomes very, very important. The excess capacity in the private sector can be innovatively utilized during times of such epidemics to avoid the shortages that we saw last year during the COVID-19 pandemic. Thank you.
Muted. Thank you very much, Professor Yonga. I don't know if any of our other panelists would like to add something before we wrap up. There are other questions in the chat. Does anyone have best practice to share on the multi-stakeholders and community involvement of triaging and assisting patients who are scared to see their doctor during COVID-19? Any insight? Maybe Chantel? Who want to take this? Chantel, you look muted.
Can you hear me now? Can you hear me?
No, not very well.
You hear me now?
Yes.
Okay, perfect, cool. Thank you. I think, for me, I suppose from my mental health care perspective, we really do need to focus on building trust in our communities. And we should really all be in the business of creating hope. And if we're cultivating a sense of hopefulness in our communities, it will certainly go a long way in developing capacity for the most basic human needs that we have, or that we have right now. And unfortunately, we've had massive amounts of increased levels of suicide, and that is not even if you have an NCD or live with an NCD, doesn't mean that you are ill specifically or physically ill. There's been massive increases of suicide in specifically during the pandemic. And I certainly think that for us to harness hopefulness, create trust in communities, is certainly the way for us to move forward and to create sort of systems and get through this pandemic in one piece.
Thank you. I hope it responds to your question. And there is another contribution, just I will conclude like that before sending, maybe before that asking Ladi, it's very strange, I'm not seeing the hands up, but Dr. Ladi would like to also contribute to the questions.
Yeah, thanks, Aminatu. I think the comment is spot on. He has really nailed on what we need to do to address the healthcare challenges that we have. But I wanted to just lend my voice to Professor Yonga's comments about the capacity in the private sector. And I think not just for governments, but I think even patient organizations should feel very free to approach private organizations. And you need to just look for a private organization that has a similar vision to what you have. And there are some, right? Whose interest and concern is about getting better outcomes for patients. And I think when you find those kind of organizations, then you can align your activities and ensure that you're putting all your efforts in the same direction to get better outcomes for patients. I think the second point that I really loved he mentioned is on the referral pathway for patients. And that is something I think we underplay and we don't do enough on in two areas. A lot of people fall through the cracks in the patient journey or in the referral pathway. And the second part is that in some cases, it takes too long from awareness to diagnosis to getting treatment, that by the time the patient gets to the point of treatment, especially in NCDs and thinking about cancers, they're already at a metastatic stage where the outcomes are really miserable. We need to do a lot of work in ensuring that we remove the barriers to the referral pathway or to the patient journey, so that patients who get picked up on time, whether it's through the challenges of not knowing where to go or religious reasons, they are encouraged to move quickly to where they can get optimal care. And then you can truly turn a lot of these terminal illnesses to chronic illnesses. And I think that's the desire of everybody, for those that we cannot cure, that we truly make the lives of the patients meaningful, irrespective of whatever NCD they may have. Thank you.
Thank you, Dr. Larry. There are other questions on the chat more related to mental health. One is actually more a contribution from Eva. The intervention that seems to help people with mental health during the COVID-19 has been interaction with psychosocial specialists who reach out to people with COVID and give them much needed psychosocial support. This has gone to several groups, including healthcare workers, non-healthcare workers affected by COVID, as well as the healthcare workers working with patients with COVID-19. So this has been well appreciated by all, she is saying, and I bet. And there is a question from Yukumaki, as like Dr. Florence on mental health. She's saying, I'm just wondering whether NCD's Alliance in Africa region also do any other activity related to oral health. I assume that FDI and IADR are part of the NCD Alliance. So it would be great if NCD Alliance in Africa region can also advocate oral health issue, since the oral health resolution will be discussed during WHA 74. Which is the first time in 14 years. I see that Tolu is typing to answer to this question. So just to monitor the answered question side. And there is another question, another comment from Obehi, who is saying, my comment is on risk communication, especially among people living with NCDs as regard COVID. Many persons are complacent when it comes to observing the NPIs, yet they are more vulnerable to COVID, and ideas on how to step up, to set this up, especially among those people, and also those they were prioritized for vaccination, yet many refuses to take. And I think that this vaccine resistance is also an issue that we are facing in many of our countries. And Vicky saying, I am the South African NCD Alliance. Everything that Chanta said was true. So just to go, she's referring back to the charter to hear more of these comments. I'm also seeing in the chat some other comments about trusting our health system and transparency and really government funding services, the need of government funded NCD services to make the continuum of care. Boniface saying that most healthcare facilities were built to fight infectious diseases. This has been maintained for long. Meanwhile, NCDs are on the rise the world over, and greatest in South Africa. So lots of comments. I refer you to the chat. I invite you also to tweet on the discussion. We are really about to finish our dialogue. That was a long session. Thank you for all of you who who've been able to stand. And really, in summary, what I could say to conclude the conversation is that people are not diseases. They have multiple health care needs, while vertical funding for specific diseases areas has been monumental. It's made it difficult for countries to support even investment across the entire health system. The pandemic has deeply underscored the importance of integrated, people-centered primary health care. Now, more than ever, a huge part of this is access to primary health care, which must include prevention, diagnosis, and treatment across the continuum of care. And investing in primary health care is the express way to universal health coverage and better protection against current and future disease outbreak. So these are basically what the takeaways that I have. One of the way PASS addresses the NCD care is through a community-based primary health care strengthening approach. This involves raising awareness in communities about the needs for screening, linkage to care and treatment adherence, training healthcare workers and community health workers to ensure we build the capacity for NCD care and ensuring access to screening and referral for those that need care. It is also critical that our ministries not only understand the needs for medicine, but also the needed self-care products. This need is especially evident for people living with diabetes. So with PASS, but also all the partners such as the Coalition for Access to NCD Medicine and Products recently embarked on the Diabetes Care Pack initiative to develop a human-centered co-packaging solutions that increases access to the required combination of insulin and associated devices and supplies. Really, I would like to end by thanking all our panelists, Professor Jean-Marie Dangu, Dr. Ifantus Mare, Leah Kilenga, Professor Kaushik Ramaya, Ferdinand Sonyoy, Professor Yonga, Dr. Ladi Hamid, Chantal Boyson, and Carl Malin for your contribution. And frankly, to all the attendees, a big thank you. A summary of the discussion will be captured in a written report, and this will serve as input toward the global charter on meaningful involvement of people living with NCD. Thank you all for your contributions, and stay tuned. And I would like to conclude by thanking a lot all our translators online. I am sure that the translation was totally fantastic. When I see the number of participants, I am also amazed by how interested you are in this conversation. I'm hoping that you will continue to interact with the NCD Alliance, which I would like to thank especially for having PASS and myself to moderate this conversation. So we look forward to the next encounter. Thank you all.